The United Leukodystrophy Foundation presents HABC, presented by Dr. Adeline Vandiver.
Hi, good morning or good afternoon, depending where in the world you're listening to this from. It's my pleasure to do sort of a retake of this HABC update, and I will also be happy to take some questions at the end of this session, because there's no way that I can address everyone's questions in advance through this type of slide. Next slide, Keely. I just want to be sure that also everybody knows that I collaborate closely with a number of industry partners. We've made the decision at the CHOP LCE that although we collaborate with them and we receive money to be able to run experiments and to do clinical trials, we don't take any personal money. And in addition, we also collaborate closely with our advocacy partners. Next slide. So I think the first thing to think about, and I know that many of you are in different places in this journey around HABC and TUP4A associated leukodystrophy. The first thing to think about is, what is HABC? So the first thing to understand is that HABC is one of a family of disorders that are all associated with TUP4A mutations. And more now, instead of calling this group of disorders HABC, which is restrictive because it refers only to those patients who have a key series of radiologic abnormalities, we're calling this group of disorders TUP4A associated leukodystrophy, because there can be really a spectrum of abnormalities and not all patients meet the definition criteria for HABC. Next slide. So HABC stands for hypomyelination with atrophy of the basal ganglia and cerebellum. And so you can imagine that there might be some patients who might have only the hypomyelination. There are even some adult patients who have only issues with basal ganglia. And not everyone who has hypomyelination, for example, has atrophy of the basal ganglia and cerebellum. Next slide. So it's also, I think, important to understand how recently this disorder has been understood. So Mario van der Knap, to whom it's very important to lend sort of thankfulness for her expertise, first identified the disorder just based on the fact that a series of children had similar appearing MRIs. And so the diagnosis was radiologically identified in 2002. Next slide, please. But it's really not until 2013 that we were able to identify the genetic cause of HABC. And the reason for that was that before, about 2010, most genetic studies were done on family analyses, where you would look at, families where the diagnosis was recurrent. And because HABC is what's called a sporadic disorder, i.e. typically occurs just once in a family, it was impossible to use those types of genetic techniques, and we really had to wait until we had things like exome sequencing readily available in order to be able to identify TUP4A as the cause of HABC. Next. And I think at this point we're in 2020, and it's really important to realize that there have only been a couple years since the gene was even identified, and that all the work that's been done to think about really fully understanding the spectrum of disease, but also understanding what might be possible to do therapeutically, has really been going on for less than 10 years. Next slide, please. Go ahead, next slide, please. So to go back a step, in 2002, right, initially children with HABC were only considered to be those children who had the hypomyelination along with the atrophy of the basal ganglia and the cerebellum. Next slide, please. And typically those patients presented as toddlers after a period of normal appearing development, and then they often would develop what's called hemidystonia, which is a medical term for saying stiffness and sometimes awkward positioning of one side, right? And also progressive difficulties with walking or gait. And over time, those children would suffer from some gradual decline in their abilities and would often have difficulties with losing the ability to walk or losing the ability to walk with support, and also have something called dysarthria and ataxia, which means unsteadiness, and also difficulties with fully being able to pronounce words. Next slide, please. And so this is the paper identifying the mutation for TUP4A. Next slide, please. But I think it's important also to know that about at the same time as we identified the gene for TUP4A being associated with HABC, other groups identified TUP4A as being associated with something called whispering dysphonia, which is an adult onset condition where patients really only have some adult problems with movement happening typically in their fourth or fifth decade of life, and then something called whispering dysphonia, which means that their voice is affected. Next slide, please. And not long after that paper, we also found patients who had only hypomyelination without any atrophy of the basal ganglia. That really made us understand that instead of being an isolated condition, HABC and the associated TUP4A mutations could be part of and result in a family of disorders. Next slide, please. And many groups have since then published additional cases, and in particular, Mario Vaneklep's group, looking at larger numbers of patients that overall show that there's a broad spectrum of abnormalities seen in this disorder. Next slide, please. So now that we have access to all that data, and now that here at CHOP also we are doing what's called a natural history study, where we're collecting information on as many affected individuals as we who are willing to share data with us, right? We now understand that there's probably 3 broad groups within the TUP4A associated loop dystrophy family. The first group, right, which is in the dark blue, is the group that was initially found to be associated with TUP4A and HABC. And those patients, just as we had noted before, typically have a period of normal development and may gain the ability to walk either with support or by themselves, right? And then over time have greater and greater difficulties. Those patients are more closely associated with a single recurring mutation that continues to represent about a quarter of the patients, which is the D249N or canonical mutation associated with HABC. But in addition to those patients, there are also 2 other groups. One, there's a group of patients who tends to present before 1 year of age, with much more significant problems with their development. These children may have significant hypotonia, may have difficulty with head control, and may have difficulty with significant movement episodes, even sometimes being confused with seizures or even sometimes having seizures. And these children often don't gain the ability to sit or stand or use their legs for walking, either supported or unsupported. And then there's another group, right, that's sometimes hard to tell from the milder group with a very mild phenotype, where they may also have the onset of symptoms when they're toddlers after 1 year of age, but over time will be likely to have a much milder presentation. And those patients may have very slowly progressive walking abnormalities, something called spastic diplegia, and sometimes also can have specific learning difficulties, and may even be diagnosed with things like inattentive, attention deficit disorder, or ADHD. Okay, next slide, please. So when we try to understand why, one gene can cause so many different types of presentations, we really try to step back and think about what cells might be affected. And one of the things that we've learned through some experiments in the lab is that, we think of TUP4A associated leukodystrophy as a hypomyelinating disorder, but really it's also a disorder that affects some of the gray matter cells, right, called neurons. And so when we think about how the mutations might affect the cells in the brain and how that might affect a person, we have to think about multiple types of cells. And this becomes very important as we start to think about treatments. So typically, hypomyelination is the result of problems with a special kind of cell within the brain called the glial cell or the oligodendrocyte. And some patients with TUP4A mutations may have abnormalities only in those specific cell types, like, for example, the patients who have only hypomyelination. Conversely, there may be some patients, like the patients who have the adult onset whispering dysphonia, who have no hypomyelination, but do have problems with their basal ganglia, and therefore with some of their motor skills. Those patients, if you look at their mutations in the lab, may have problems only with the neurons. And then there may be patients who have mutations that might affect both cell types, right? And that includes those patients with classic HABC. So when we're thinking about treatments for this group of disorders, we're going to have to be very thoughtful, because a lot of times different treatments might get into one cell type more effectively than another. And in addition, some of those cell types might be represented differently in different parts of the brain, for example, in the cerebellum or the basal ganglia. And so it becomes very nuanced trying to think about treatment options to make sure that we get at the significant actors, so to speak, in this disease. Okay, next slide, please. So more specifically, let's dial down a little bit more about how TOP4A mutations can cause problems in the brain. Next slide, please. So I don't know, Keely, if you click on that, if you can get the video to come up. Okay, it looks like it's not working. Okay, so I think any of you who are watching this from home, I would ask that later on you click on something, you look on YouTube for a video called The Inner Life of the Cell. It looks like Keely is going to put the video into a YouTube chat. And Keely, if you put the exact link that I shared, it should start at the right point, and then people can look at it later or during the talk. Go ahead. Go to next slide, please. This is a really nice video that details a lot of the way cells work within themselves. And there's one part of that video that shows very specifically how microtubules assemble, right? And you can see here, it's a still shot, but what you can see is that there are these little dimers, these groups of 2 proteins called dimers that assemble together to form this special tube called a microtubule. Go ahead, next slide, please. And TUB4A is one of those little groups of 2. Right? And together, those little groups of 2 will assemble and disassemble to form microtubules. And you can think of microtubules as if they were the roads within the cell. But imagine that instead of having a car that you drive down a road that's there all the time, if you decide you want to go to the grocery store, there's a message that goes out and says, okay, we need to make a road to the grocery store. And that road literally is made right before you as you're moving towards the grocery store. And as you're going towards the grocery store, also the road back from your house is actually also getting picked up and getting moved around. So the cell has these very intricate mechanisms by which, in order to move proteins around, they will actually build these roads to move things around within the cell. And TUB4A is a key part of those roads. Next slide, please. And what we know about some of the mutations is that depending on where the mutation may be in the TUB4A, it might affect how the TUB4A attaches to the TUB-B, which is that other part of that little dimer, right? And also how those little dimers, those little groups of 2 proteins, might all attach together to make microtubules. And that may mean that either the road can't assemble properly, it can't be made, or that the road gets stuck and that it doesn't disassemble, right? And that you have crisscrossing of roads all over the place that don't make any sense anymore within the cell. Or maybe that the cars or the proteins that are called the motor proteins that move things along those highways, the cars can't somehow attach to the road. And it's likely that when we're seeing these different type of effects from different mutations, it's because different parts of the role of TUB4A are affected. Next slide, please. And this just shows, for example, how, and it's very nicely showed in the video if you get a chance to watch it, how there are special proteins called molecular motors that will attach to that road and sort of drag these big unseemly looking proteins along with them. And when we think about cells, we have to think about the fact that different cells do different kinds of jobs, and that the cells that make your myelin, the oligodendrocytes, are responsible for a really, really complex series of juxtaposition of proteins to make that myelin. And so that it's likely that these processes of moving things around within the cell are particularly important to certain brain cells, and that may be why brain cells are more likely to be affected by TUB4A mutations, or certain types of brain cells are more likely to be affected. The TUB4A is only one of many kind of tubulins, and other types of tubulins are important in other parts of the body. Okay, next slide, please. So because we wanted to better understand how TUB4A affected the cells of the body, we created a bunch of tools in the lab that can be helpful to better understand how these special proteins and how mutations of these proteins might affect the function of the brain. So the first thing that we did is that we were able to give the same common mutation, that mutation that I told you represents 25% of the overall mutations, to a mouse. And we were able to show that that mouse has a lot of the same features as people who are affected with that mutation when it's in a human person and not in a mouse. So the mice begin to have problems with their walking, and over time are unable to continue walking as well as they are before, and they also develop dystonia. So that's not nice for the mice, but it is very good from the perspective that we can then apply treatments to that mice and try to cure that mouse and share then our understanding of what may be helpful in HABC. The other thing that we've done is we've actually, through donations of families who make a donation of a blood sample, we can take samples from that blood, and then you can actually make those blood cells into something called iPS cells, which are pluripotent stem cells, and then make those pluripotent stem cells that come from people with different TUP4A mutations and actually make them into different kinds of brain cells. And so we're also doing that. And so we can also show, based on that, what kind of therapeutic approaches might work in brain cells. It's not obviously as complex as an entire person would be, but it gives you some sense and can help us balance and understand whether or not some of the things we're trying in mice might also work in human cells. Next slide, please. So overall, right, what we have learned so far is that it looks like the mutated TUP4A alters the ability of those microtubules, those special little information highways within the cell, to be made and to also be removed, right? And it probably creates an accumulation of those different microtubules within the cell that can be very problematic for the function of the cell, and also affects the ability therefore, of special brain cells to do certain tasks. In neurons, it's probably that those neurons are no longer able to make the right networks within the cell and therefore survive because they can't send the right chemicals within the cell to do its job right. And then in oligodendrocytes, those special cells that make the myelin, it's probably going to really affect the ability of the oligodendrocytes to bring the right myelin proteins to the surface of the cell, where they have to wrap around the neurons to make the myelin. Next slide, please. And so you really can think about the mutated TUP4A as a protein that, because it's not working well, right, sort of gloms up and is a grain of sand in this very complicated gearbox that is these brain cells and how they work. And one thing that we've been considering in the lab is what would happen if you were to remove that grain of sand. Next slide, please. So we think a lot about potential therapeutic strategies, and I'm going to go over them at a high level, and then we can ask some questions about it later. Next slide, please. So overall, right, the idea is that if we could remove, right, in different ways, the mutant protein, or make that mutant protein less prominent, we would be likely to be able to help these cells a lot. The part of the idea is that TUP4A is one of many different kinds of tubulins, and that there's some evidence that suggests that if you get rid of the mutant protein, you'd be more likely to have it be replaced. You'd be more likely to, sorry, there was a chat that distracted me for a second. You'd be more likely then to have other tubulins take the place of that tubulin and be able to do the job so that the microtubules could assemble more normally. And there are different ways of doing that. One way is by using something called antisense. When we go to the next slide, please. All right, where you can actually keep the protein from being expressed, and other ways are actually to use genetic manipulation to actually overall change the protein. So some of the reasons why we think this will be effective is because if you take a mouse and you remove TUP4A altogether, that mouse is normal, right? And if you take the TUP4A mice and you treat them with the antisense, we may be able to see whether or not we can make them better and sort of transform them into those same mice, the mice like the knockout mouse, which don't have TUP4A at all. And then the other approaches that we have been using is we've been using something called CRISPR, right, which corrects or does gene editing. And we know that in cells, at least, we can correct the cells and make them appear to be more normal in their function. Okay, next slide. So I think, obviously so far we've been talking about mice and about cells, and there's a big gap between sort of how we get from there to getting to actually having something that's ready to go into people. And one of the gaps that we need to fill is natural history studies. Next slide, please. So natural history studies, right, are an approach where we try to understand what happens in the disease, right, without any intervention. And the reason why it's so important to understand that is because if ever we want to be able to suggest that a treatment is effective, we need to have something to compare it to, right? And, sometimes it can be feasible, or is important to do something called a placebo-controlled trial, where you give a treatment to one group of people and you don't give a treatment to another group of people, and then you can see by how they do differently whether or not the treatment has an effect. But if the progress of the disease is very slow, right, as it is in HABC, that might not really be realistic and feasible. And so we might really have to understand how the disease progresses by itself, even without having a full placebo group, and we might not have the luxury of having that kind of trial design. And so the other reason why it's important to do a natural history study is because it may be that there's a subgroup of patients within an overall population that might be the best population to try a treatment on at first. And that doesn't mean that the treatment that's tried on those patients isn't going to work on other people, but it might mean that the only way that you can definitively prove it, because some patients are getting sicker faster and therefore you can show more quickly that you have an effect, it might be that it makes sense to start with a trial in one subgroup of patients. And so that's why natural history studies are very important, is because it can help you understand how long does it take to see change? Are there some patients in whom you might see change faster, who might be more sort of easier to demonstrate a change with a treatment, and also make sure that we understand fully what kind of effects the disease might have, so that if at some point we do a trial and something, and patients develop certain symptoms, we know for sure whether or not it's related to the disease or related to the medication. So for all those reasons, it's very important to start natural history studies. And as I mentioned to you before, because HABC has only been known for such a short amount of time, we don't have a lot of historical data to be able to rely on to understand what might happen in HABC over time. Next slide, please. So the limitations of a natural history study is sometimes, they may happen years before a clinical trial, right? The groups may not be big enough to detect every potential problem. And also sometimes a clinical trial might be ready before they're completed, and we might not have enough data to test the trial without a control group. So natural history studies that you're doing before a clinical trial are not perfect, but they can help you a lot and set things up so that you can do the best job you can in designing a clinical trial. Next slide, please. So I think that the other thing that's important to know is sort of the other reason why natural history studies are important is for something we call anticipatory guidance. So anticipatory guidance is what your pediatrician does when you go to the pediatrician and they say, oh, at this age, there might be teething. At this age, there might be, more difficulties with certain types of problems because the child is undergoing this stage of development. Or, at this stage, for example, please be careful to cover your outlets and make sure that things at sort of toddler level are protected. These are all things that pediatricians do all the time for anticipatory guidance. But there doesn't tend to be anticipatory guidance for rare disease. And so one of the things that we find really important that we've been really focusing on is that there's a lot that can be done for symptom management while we're waiting for potential therapies to make sure we keep children safe and to make sure we anticipate problems rather than have to be reactive to them. Next slide, please. So, it's really our stance within the Literature Center of Excellence at CHOP that these anticipatory guidance are equally important for health milestones in children with chronic disease, so we can make sure that we can anticipate and help with problems before they start being clinically visible. Next slide, please. And so we're hoping, right, that approach can help reduce illness and hospitalizations and other complications in children affected by leukodystrophy, right? And we're also working around natural history to have best practice guidelines for really good timing of specific health milestones that might occur, such as greater difficulties in chewing and swallowing, or challenges with urination, breathing problems, and things like that. Go ahead, next slide, please. So the important types of it's important to consider all organ systems. So go ahead and Next slide, please. I might ask you to go backwards. So go ahead. Sorry, back one more slide. I apologize. So when we're thinking about HABC, I think the important things to think about, while we are working to understand therapies, is what kinds of things we need to worry about in the here and now for HABC. And for HABC, really, we're lucky in some ways that there's some leukodystrophies that affect multiple organs in the bodies. And HABC, really, we think that predominantly or almost exclusively the problems are occurring with the brain. But that does mean, however, that we need to think very carefully about certain aspects. So it's very important to, if you have a child who's affected by Tupper leukodystrophy or HABC, that you are embedded in a team that also includes a rehab doctor. Neurologists are great at thinking about things like seizures and in helping you make a diagnosis and helping with some types of management of the symptoms. But rehab doctors really are focused on the functional aspects of the child and are particularly good at helping with things like tone management, which are very important in HABC, and can also help recommend specialized techniques such as Botox in some cases, specialized medications for tone management, and also, if needed, additional procedures, backlift and pump placements and things like that. And that having that as a partner with you to work with the physical therapist and the occupational therapist who will be seeing your child or your young person is very important. It's also very important to work with an orthopedic surgeon because we know that the increased tone in HABC can cause problems with the hip joints in primarily, and also can cause problems with scoliosis. And having an orthopedic surgeon that you can go to for monitoring and to make sure that the best steps are taken to preserve function and the ability to stand and weight bear is also very important. It's important to think early and often about feeding. And one of the things that's particularly challenging, I think, in HABC around feeding is that people with HABC, just like they may have fluctuating motor tone in their arms and legs, and you might have sometimes where they're better and sometimes where they have a harder time, that fluctuating motor tone can also affect the ability to swallow. And so we tell our HABC families that in all cases, families with HABC should be very careful about certain consistencies of foods that might be more likely to cause problems with choking if all of a sudden there was a tone change in the swallowing ability. And so, just like you might be careful about giving a child under the age of 3 certain types of foods, and those include hard nuts, hard candy, large amounts of bread or meat, things that don't break down easily, and then also objects that are not that need to be cut up, such as grapes or cherry tomatoes or hot dogs, need to be cut up in little pieces so that they don't present as much of a choking risk. Those are lifelong recommendations for people with HABC, even if they appear to be chewing well, should always be taken into consideration because you can have fluctuating swallowing problems related to the dystonia. Also very important are working on as many different types of communication abilities as possible for a child, because the child's speech and ability to make sound may vary over time, and so those are important things. And then a final thing that I do also want to say is that we've had a couple of children with differences in some of the large blood vessels that come out of their heart. So we do recommend that every patient with HABC be seen at least once by a cardiologist, just as a baseline test. Okay, next slide. So I think, a lot of families want to know what they can do now to support research. And, we're always so grateful to the families who reach out to us and who support research in various ways. And for some families, that means, making a foundation and driving research on their own. But for other families, that means participating on a one-on-one basis by joining a natural history study. So different things that you can do is you can reach out to support your advocacy partners who are doing a lot of the heavy lifting, trying to move the field along. You can also participate in a natural history study, and I want to emphasize that doesn't have to be in person. You don't necessarily have to travel. There's a lot that can be learned just by sharing medical records, right? And then, you also want to continue to find ways to be informed through your local medical teams about healthcare choices and options for participating in clinical trials as they become available. Next slide. So I think that's the end of the slideshow, and I'd be happy to, take any questions if any questions have come up during the talk.
Absolutely. I can hear an echo, so I just wanted to make sure I'm not, okay, I don't hear it anymore. So we do have quite a few questions. So everyone that's watching on YouTube, please feel free to enter them into the chat, and then I'll read them to Dr. Vandiver so that she can answer. Thank you all for watching. So let's get started with the questions. The first one is, how do patients get the mutation in TUB4A gene? Is it a spontaneous mutation?
That is such a good question, and I'm sorry I didn't bring it up. I should have. So, there are some mutations that are inherited, right? And that means a mutation happened a long time ago in an ancestor. Your parents are carriers, right? And the mutation is transmitted to you at the time when when the sperm and the egg form to make the new person. But there are other mutations that happen actually sometime, after that sort of ancestor of yours, and either they can have happened in the sperm or the egg, or they can even happen very early on when the person is just a small group of cells. And we used to think that those events were very rare, right? But now that we can do genetic testing, of all your genes in a very large scale fashion and on a lot of people, we realize that every person has basically hundreds of changes within their genes that make them different than their parents are, right? And so not all of the variations in your genes are actually inherited from your parents. Now, a lot of the times, right, this variant might occur in a place that makes you a little bit more or less gifted at music, or a little bit more or less gifted at sports than other people in your family, and create all the amazing variability that is part of human nature and makes us all the unique people we are. Sometimes, though, those changes might happen in a more critical place in the gene, or a more critical gene, and then have a result in disease, right? And so that's what happens in HABC. The mutations are typically what's called sporadic, which means they happen just in the person. Very rarely they can originate in the egg or the sperm, and so they're very rare cases of something called mosaicism, where a parent might not have a TUB4A mutation in all the cells in their body except for in eggs and sperms, and then you might have more than one child in a family. But most often, children with HABC are by themselves. As far as genetically, they don't have other affected members in their family. They're obviously not by themselves. They're just surrounded by their family, but by themselves genetically. The exception to that is that group of patients with what I call that whispering dysphonia, where because the TUB4A mutation is very, very mild, in those cases it's handed down from one parent to another, from a parent to child. I hope that answers that question.
Yes, and there is a follow-up question that's, I believe you've already answered it, but if it triggers any additional explanation, great. It's when is the mutation made, at birth or after the birth and during the brain development?
No, it's not at birth or after birth. It's well before that. When again, like I said, either when the person is just one cell or just a couple of cells, or in more rare cases when coming from the sperm or the egg. But we think most likely those changes are happening really at the time when those first divisions of cells are happening.
Okay. And then additional question from the same person, why does the problem only occur in white matter and not gray matter?
So actually, that's not totally true, right? So the cells that are involved are the white matter cells, and then special gray matter cells, special neurons. So it's affecting the basal ganglia and the cerebellum. So actually, it's not a disease that only affects the white matter. It's a disease that affects multiple cell types, and that's one of the things that's going to make therapeutics challenging, because you're going to have to get that treatment into all those different cell types to be fully effective. The reason why, though, that mutation doesn't affect other parts of the body, right, is because TUB4A is the tubulin that matches those cells, right? Other cells in the body, like your liver cells or your skin cells, they also have tubulins, but there are other types of tubulins. And so the reason why those cell types are primarily affected is because they use TUB4A to make their microtubules.
Okay. Next question is, will the treatment be intended for all children who have HABC/TUB4A impairment, or does the study focus on only one version and one common mutation?
That's a great question, right? So the types of treatments that we're focused on first, which is things like antisense, right, will be will not focus on a specific mutation, right? And I think a lot of the different early therapies will probably be independent of specific mutations, because what they'll be geared towards doing is just making you have less TUB4A, right? And less of the mutant. And it won't matter what mutation type you have, it'll just be trying to get rid of all of it, right? Later on, but I think that's really will not be the first approach, is gene editing, right? Which is something where you try to go correct a specific mutation, obviously is much more personalized. And those approaches may at some point be for specific mutations, but once it's demonstrated to work for a specific mutation, there'd be no reason to think you wouldn't be able to do the same for other mutations. But otherwise, no, all the therapies that we're focused on are focused on overall all mutations. Now, like I tried to explain, that doesn't mean that in a clinical trial, because you might have to really find a way to, within a few short years, be able to answer the question is, does this therapy work? That doesn't mean that in a clinical trial there might not be some selectivity, right? Because you would have to, for example, say, in clinical trials are typically something called inclusion criteria, right? And those inclusion criteria might be how far along the disease is, what type of mutation you have, how old you are, right? Clinical trials often come with some inclusion criteria, but the goal is not to exclude people. The goal is to find those patients that are going to allow us to the most quickly and efficiently show whether or not that therapy is effective, so that then it can be shared with everybody else.
Great. And follow-up question still on treatment. Will future treatment stop the progression of the disease, or will it also improve the functioning of the children?
That's a great question. It's one we don't know yet. It's one we hope we'll have a better understanding of once the work in the mice is a little bit further along, right? Because really what you're asking is, like, once you stop the tubulin from being a problem, can the cells repair themselves? And that's likely to be a complicated question, because there's some type of cells that do repair themselves well, at least up to a certain stage of the disease. And so, for example, oligodendrocytes might be able to repair themselves because you continue to make myelin, during your entire life, right? Whereas there might be other cell types, if there's already been a lot of damage, like for example in the cerebellum or the basal ganglia, that can't repair themselves. And so it's likely that won't be a sort of like all or nothing question, right? And we may have some hint of what's going to happen once we once we fully see everything that's going on with the mice, but we likely won't fully know. Sorry. Excuse me. We won't fully know until we see what happens when we start treating people.
Great. Okay, there is one final question that has been submitted through chat, but a vocal reminder, if anyone does have any additional questions, feel free to throw them in the chat feature. Otherwise, Dr. Vandergrill will be signing off after answering this one last question, which is the treatment you are considering intended for a certain age, or can it be given at any age?
That's a great question. And again, we don't know yet fully, because we won't know until we have a better understanding what the treatment does, if there's a potential for recovery, right? If all the treatment does, quote unquote, is to stop the progression of the disease, some families may decide that whatever risks the treatment has, right, is not worth it if somebody has already lost a lot of function, right? Other families may decide it is worth it, but it might not be everybody, right? Versus if it's a treatment that seems to cause some reversal of the symptoms, at least to a certain time point, then that will probably change a lot how people feel about the treatment. So that's not a question we really have the answers to at this point.
All right, one more question did come through, and I think it's a great question to wrap the session up on. How is your research being impacted by COVID at the moment?
Great question. So we were very impacted in the first couple of months of the pandemic when the complete shutdown was obligatory. We had a period of about 8 weeks where we weren't allowed to be in the lab, except to just take care of the mice in the labs and take care of the cells in the lab, but we weren't allowed to make progress. But that now is behind us, and we have created techniques and approaches so that we expect to be able to continue working unabated, right? That doesn't mean, so that's for the research in the lab. The natural history work is actually much more impacted, because it's much harder for people to travel right now to a site to get assessed. And that makes it all the more important for people to participate remotely and to share information so that we can continue learning about the natural history while the pandemic is preventing as much in-person interaction and travel.
All right, and looks like one more question did sneak in. So final question, and then Dr. Vandiver will be signing off. The last question is, when will you get FDA approval?
So FDA approval only happens after a clinical trial, and we're not yet in clinical trials. So we have no timeline for that right now, right? Because remember, we're still testing the approaches in mice. Then we have to say, okay, then we have to do what's called clinical trial design, where we have to design what the trial will look like. Then there has to be a clinical trial, and then the FDA has to review that data, right? So FDA approval is like the very final step. If what you meant by FDA approval is when will you have approval from the FDA to start a clinical trial, that will depend a lot on the next 6 to 9 months and what the data looks like coming out of that. So we'll have more updates for that, but no, we don't have an answer yet.
All right, great. Thank you so much for your time today, Dr. Vandiver. And thank you to everyone on the YouTube side who watched with us live. If the link to the YouTube video that Dr. Vandiver had tried to share earlier, we will be posting it onto our Facebook page. And once this hits, the recording hits YouTube in the next week or so, we'll have the link in the description box as well. But if you don't happen to see the link, please shoot us an email at office@ulf.org, and we'll be happy to send that video to you that way as well. So again, thank you so much, Dr. Vandiver, and everyone have a wonderful day.
Thank you. Goodbye, everyone.